I wanted to just give a brief introduction for those of you who don't know who I am. And this is just to give some background into my medical education and the type of things I was doing in Canada before I ventured out into the world. I have a medical degree, obviously, but I was doing a Health Canada approved clinical trial using patients' own stem cells. So this is from the bone or fat, and we'll talk more into detail about the next generation of stem cells today, but that was really for osteoarthritis and for degenerative joint pain. And then I was also assistant adjunct clinical professor at University of Toronto, and I was teaching residents and medical students about orthobiologics and how to use these regenerative substances using the best available evidence that we have, but also applying them clinically. And then from there, I kind of went on to explore other opportunities because in Canada we have amazing research in stem cells, but the regulation is very strict there. So you can't actually do a lot of those therapies outside of research settings. And so I went into places like Dubai, which is where I am currently, and we're allowed to do certain therapies there. In parts of Europe, in Florida, we also have a clinic that we're opening because we're allowed to do stem cells there. So we're just kind of trying to get these into patients to help them in the real world setting, but then at the same time now trying to do more research as well. So really what I want people to understand today, because unfortunately I only have 25 minutes, so I have to be pretty fast, but I will try my best to at least focus, because this is more of a longevity focused conference. I will focus on how these MuseCells, I think, are going to be one of the leaders in longevity interventions over the next few years as we get more research about them. And so the name Dazawa MuseCells is named after Professor Mari Dazawa, because she was the one who discovered these in 2010. And a lot of people didn't find out about them because Professor Yamanaka, of course, also had a big discovery called induced pluripotent stem cells, iPSCs, in 2006. And I think her work just got a little bit overshadowed. As far as I know, I was the first doctor outside of Japan, the first medical doctor outside of Japan to use these MuseCells clinically. And now we're doing research with them too, and we're working with Professor Dazawa in her lab, which is in Sendai in Japan, for various applications. So I think a lot of the audience probably has heard of the word stem cells. Stem cells, unfortunately, doesn't really categorize, it doesn't really explain very well the difference between different types of stem cells, because there's so many different types of stem cells. It's not just like one stem cell and it's all the same. There's some stem cells that are very useful, and there's some stem cells that can even be harmful. So you have to be careful what you're putting into your body and what you're using. And the very interesting thing about MuseCells, as the name stands, so it stands for multi-lineage differentiating stress-enduring cells. And what that means is it has a tri-lineage capability. So meaning it can turn into pretty much any cell in your body. So meaning it can turn into a heart cell, it can turn into a brain cell. And this has been shown in the research in animal models, and then in some of the clinical trial work that she's done as well in humans. But that means they're pluripotent. But the interesting thing about MuseCells is they're pluripotent, but they're non-tumorigenic. And this is a very important factor in their clinical application, because the risk with iPSCs and embryonic stem cells and other pluripotent stem cells often is the risk of tumors or cancers. But with MuseCells, you don't have that same risk, which is what makes them exciting, and I think at least gives us more peace of mind using them in a clinical setting. And the good thing about these, because they're technically a subpopulation of mesenchymal stem cells, MSCs, which is the most commonly used in most clinics and most well-researched. So they're just a subpopulation. So meaning when you take umbilical cord stem cells from a donor after C-section birth, or you take it from the bone marrow, there are MuseCells in there, but they're only a small fraction. They're only 1 to 2%. So instead of having only 1 to 2% of MuseCells, what Professor Dazawa is doing and what we're doing with her is essentially you're standardizing the cell population to have at least 70% MuseCells as a minimum kind of standardized cell population. What this does is it allows for a product, kind of like an off-the-shelf product, an allogeneic off-the-shelf product that has a standardized cell population. Because one of the biggest issues with MSCs is heterogeneous. So meaning you have different cell populations. So now you have a homogeneous cell population and it's more reproducible. It's more like a drug that can give you consistent results. And so that's the reason why it's more exciting for clinical application as well. And then the other big thing on the last note here is no need for HLA matching or immunosuppressants for donor cell use. So meaning you can take these safely from a donor, from someone who doesn't have your same DNA, and your body will not reject it. And I'll go more into details about why that is exactly, but the point is you don't need to take immunosuppressants, and there's been safety data shown in phase 2 clinical trials, and no form of rejection or anything like that. So this is just the main point I wanted to highlight here versus umbilical cord mesenchymal stem cells versus the MuseCells. The big thing is getting trapped in the lungs. The homing mechanism is one of the other unique properties about MuseCells, meaning they can actually find, so if you just do an infusion of them, they can find their way to the injury site. It kind of sounds like hocus pocus, and when I first heard it, it's like how can the cell find out where the problem is? So but they've published tons of data and evidence on how they can do this, but importantly, the mechanistic data seems to translate into clinical data too. So for example, they did a phase 2 clinical trial with stroke patients, and they didn't inject the MuseCells into the brain. They just did an IV, just a drip, where you just sit there for 1 to 2 hours, and it was a relatively low dose too. It was just 20 million MuseCells, and essentially they found significant recovery in 25% of the patients, and then the other 75% still had improvement in their ADLs and other measurements. So that shows us that clinically, even if you just do an IV of these MuseCells, they can find their way to the brain, or they've also done clinical trials for heart attack or MI, and they were able to show repair and regeneration in the heart as well. And again, this was just an IV, not direct injection into the heart. So that's a really unique capability of the MuseCells. And then the other big thing that I was talking about earlier is the immunoprivilege. So MSCs, they can kind of evade your immune system, but eventually they do get phagocytized by macrophages, and they do kind of cause, and then they can reduce inflammation, but they don't engraft into the body. What these cells do is because they're immunoprivileged and because they're pluripotent, they're able to actually engraft, and the mechanism by which they do this is called phagocytosis, meaning the MuseCells actually eat damaged cell fragments. So, for example, if they go to the heart, if there's damaged heart cells there, they'll eat them, and then they'll use a cellular machinery to turn into a new heart cell that's functionally younger and works better. So that's kind of the mechanism by which we think these work. So I kind of talked about this a little bit, just about being able to standardize and being able to standardize the cell population. Just because of time limitation, I am going to go quickly through some of these slides. But yeah, so this is one of the important things that for people interested in longevity and people interested in cellular rejuvenation, so to speak, pluripotent genes like NANONG, OCT4, SOX2 are very important for having that effect that we want of kind of epigenetic resetting or epigenetic reprogramming. But then you don't have the c-MYC, which is what you have in the Yamanaka cells or iPSCs, which is what has been linked to tumorigenicity. So that's a unique thing about the MuseCells. They have these pluripotent gene markers, but then they don't have the risk of tumors, the c-MYC. And again, this is where I talked about all these kind of points. If they can turn into different cells. They don't have the risk of uncontrolled proliferation because they're stress-enduring cells. So stress-enduring meaning they can survive. The brief story, just to understand how these cells were discovered, it was actually a very interesting story. Professor Mari Dazawa, she was going out for drinks with her friend. So she was going to go out for drinks, and then she left this enzyme, I think it was trypsin, in the petri dish, and then all the cells, by accident, All the cells had died except for this one cell, and she was kind of puzzled. She's like, why is this cell still alive? And then she characterized it and realized it's a different type of cell population. And then that's part of the reason why she named it the MuseCell, because it's stress enduring, meaning it can survive in harsh environments. Because again, with MSCs and a lot of traditional stem cells, when you put them in the body, 95% of them may die based off some of the animal research that's been done on that. So MuseCells have a unique ability to survive in the body too, and then they have that unique ability to integrate into the body because of their phagocytosis and the pluripotent genes. So this was just more details on the homing mechanism, which we talked about, and some of the data she's published in animals showing how the MuseCells are able to engraft into different tissue, and how they're actually able to proliferate and turn to new tissue, not just reduce inflammation. And yep. Okay, so some of the clinical trials, I talked a little bit about the stroke, and this was the study specifically, some of the details around it. And again, it was very interesting because it was just an IV, and it was just one infusion. The thing about the MuseCells is, we're using them clinically. You can infuse them multiple times to get the treatment result you want. And I think the dosing is something that still obviously needs to be figured out with more research. But with just even one infusion, you're able to see significant improvement. This was in 35 patients, so it's not a huge sample size. But the point is that we're able to see in a randomized clinical trials showing significant recovery with IV MuseCells. And I think that's really the take-home message there too, is the safety. There was no need for immunosuppressants. There was no serious adverse effects. In medicine, we're always looking at number needed to treat versus number needed to harm. So NNT versus NNH, so to speak. And so I think when you have these interventions that are very safe and there's a very low risk of harm, it makes it much easier as a clinician to be able to apply them to my patients, and obviously want to do research with them because of their high safety profile. And then I think for acute MI is one of the most exciting ones too, because you can see the left ventricular ejection fraction improve from 40 to 52%. So this is just one infusion of 15 million stem cells, 3 to 5 days post-MI after a heart attack. So in acute settings, these cells can be, I think, even more helpful, because when there's acute inflammation, the MuseCells can sense that inflammation, and they can go there and home in, and then they can do the integration and actually turn into new functional cells. So I know one of the plans that Professor Dazawa and the group is hoping to do is they're actually hoping to do they've already done a phase 2, but they want to do a phase 3 trial, hopefully for MI. We're looking at FDA, hopefully under FDA, and then that would be one of the indications potentially that this would get approved for. So the ALS trial was smaller. It was only 5 patients, but it was kind of just to show if there could be any sort of effect. And this was 6 monthly IV doses, so once a month for 6 months. And with ALS, as people probably know here, there isn't really a cure for it, and it's not like MuseCells are a cure for it, but they're safe and they may they may have a slowing effect. So I think obviously with ALS and a lot of these chronic complex diseases, you kind of have to take a holistic approach where you have to look at multiple factors like the microbiome, toxins. There's so many other things that play a role in these chronic diseases. So it's not as simple as just putting MuseCells in the body, but I think the point is that there is some safety data coming out and potentially some efficacy. So it is obviously something we are going to explore further, because there is really no good treatments for ALS at the moment. And she just published a study, which I don't have on here, but this was just published a few months ago, showing intranasal injection of MuseCells for Alzheimer's disease can also be helpful in neurodegeneration in that case. So I think that might be an interesting application for the MuseCells too in the next few years. And so just for time, I'm going to go. So there's been, just to show that there's been clinical trials for neonatal hypoxic ischemic encephalopathy, spinal cord injury, and this was just kind of a summary of the different clinical trials and some of the data. And again, as you guys know with clinical trials, especially to do large clinical trials, it costs a lot of money. So this was kind of what she could do with the funding that she had at the time. But now we're working on getting more funding and hopefully doing more research and hopefully doing larger randomized clinical trials, because then we can really show the data. And of course, my interest is longevity, because that's just personally what I'm interested in. So I'm going to talk a little bit about why I think MuseCells are going to be kind of one of the best interventions for longevity and anti-aging. So this is just for orthopedic applications, meaning, we've had patients with like chronic back pain, shoulder tears, all sorts of things that we've been able to fix with the MuseCells, and and just showing kind of images before and after of edema and other things reducing. And we use them in advanced osteoarthritis, and we're just a quick note on, for arthritis treatments, we will treat the bone too, where we go intraosseous directly into the bone, and then we do what's called a hydrogel scaffold into the joint. Because the problem with stem cells, when you inject stem cells into a joint, whether it's a hip or a knee, within 24 hours, only 2% remain within a weight-bearing joint. So most of them migrate. So you need a scaffold to keep them there. And so we're using a hydrogel scaffold, which we've done some research on, that can actually increase the MuseCell viability and their metabolic activity too. So if you have the right type of scaffold, it can actually work synergistically with the MuseCells at a mechanistic level, but then of course it can lead to better clinical outcomes because the MuseCells are able to stay where they're supposed to and do their job of repair. And we're just starting to get back some data on cartilage regeneration, and we are also starting a phase 1 clinical trial for knee osteoarthritis. That's actually just started next month. So this is just more clinical cases, and the one obviously I want to talk about here is for longevity, because that's what this conference is all about. But there's so many different applications. I mean, long COVID and different chronic illnesses that we've been able to use them for, and chronic pain. So yeah, the longevity is of course one of the biggest interests, because the MuseCells, there's a few mechanisms by which they work in terms of how they slow down aging in the body. And again, this is just an IV. So it's a very simple intervention to be able to actually reprogram and slow down the aging process at a cellular level. And one of the ways they work is there's these nanotunnels that they create, the MuseCell, and they transfer the mitochondria from one cell to another cell. So now you have new mitochondria that you essentially have mitochondria DNA repair, or fresher mitochondria, and then you also have what's called mitophagy, which is repair of damaged mitochondria. So mitochondrial optimization is one of the big mechanisms, and then the other big mechanism is immune system regulation. So for the aging experts here, I'm sure you guys know that there's so much research coming out about how the immune system aging is one of the best predictors of mortality and in terms of the aging process in general. If you have an accelerated immune system that's aging, that can predict your risk of diseases down the road. We know whether it's cancer or autoimmune conditions, but just age-related diseases in general. So if we can make your immune system slow down the aging process in your immune system, then we know that we're having a good effect on the whole body in terms of aging. And so what we do is we have something called the golden bag, which is just like it's a commercial name, but it does work well because it's basically Muse stem cells, Muse exosomes, and umbilical cord plasma, which is young plasma. And that's one of the things that we do for a lot of our patients who are interested in longevity. So this is just kind of some of the commercial stuff that we offer, and in terms of why a lot of people are interested in this stuff because they're looking to slow down the aging process. But again, the biggest problem is having data, right? You want to actually have data to show that these things are actually doing what we're saying they're going to do. So this is some of the cosmetic applications, and then in terms of complications, the IV is very safe. I mean, with MSCs, sometimes you might get an immune reaction. MuseCells is very rare. I've done it for hundreds of patients. I can think of one patient who's actually had a bit of an immune reaction that lingered. But for the most part, it tends to be very safe in terms of not causing a sort of immune response or any sort of transient fever or anything like that. So I think one of the future options, which we're looking into now, is autologous MuseCells too, because imagine if you could take MuseCells from your own blood, and your MuseCells, whether you're 30 years old or 40 years old, may not be as good as umbilical cord MuseCells, but imagine if you could use cellular reprogramming and partially reprogram them and make your MuseCells young again. So now you have young MuseCells that are 100% your DNA, and they're from your own body. And I think that's one of the areas of research we're doing right now, and I think that will be a huge potential intervention for longevity as well. This is just kind of the protocol that we have for some of our patients in terms of trying to get their body ready for the MuseCells. And what I really want to talk about before I run out of time is just some of the data that we're starting to get back. This is using biological noise. Biological noise is essentially, if you think of your body like a symphony where all the instruments are playing together over time, there's more background noise, there's more static, and there's more mistakes being made. So this is just one way to quantify the aging process. You can see this was about 6 months so before the test and after the test. You can see the blue here, that indicates reversal of the aging process in different organ systems. But the one that was really interesting to me is the inflammation and the immune system biological aging. I think that's a really interesting one, and I'm really looking forward to doing a randomized clinical trial with these cells where we have a placebo group and everything, and then have a large data to really show the power of what these cells can do. But just based off some of the real world evidence, we're starting to see actual changes based off the data, and then subjectively, people will say they actually feel younger. You know, they have more energy, recovery. So there's actually subjective improvement, but then there's also data to kind of back up these interventions and what they can do. So I think I'm pretty much out of time, and yeah, this is just to. I kind of took the backwards approach to this. These are the Kardashians, Kim and Khloe, and they have 300-something million followers on Instagram, so they probably have one of the biggest reach in the world. And the reason I chose to work with big celebrities first was because once you work with the big celebrities, you're able to kind of raise awareness on the potential of these, and then you're able to get funding. A lot of them will support you, and a lot of them have high net worth individuals who support you to do the clinical trials that you need, because eventually those clinical trials are very expensive. So that was the way I chose to do it, and now I'm planning to do a lot more research, and I'm excited to kind of really show the world the power of these cell therapies. And that's pretty much it. Thank you for your attention.
I've heard that you've mentioned this therapy to treat long COVID. Can you elaborate more on the whole process of how you do that? Because I'm also like researching on long COVID. Basically my research is like long COVID using rapamycin and antiviral combination therapy to treat long COVID. Because like right now, long COVID, you don't have any biomarkers to like objectively measure whether you have long COVID or don't have long COVID, and also you don't have any of the biomarkers to measure like your symptoms. You can only based on like subjective measures.
Yeah.
Like, so how you guys and how you groups like do that?
Yeah, exactly. It's often it can be a diagnosis of exclusion, right, where you've ruled out other possibilities, and then you kind of relate it to the history. And so I think mechanistically, we know with long COVID, they get neuroinflammation, they get mitochondrial dysfunction, they get immune dysregulation. So essentially, the MuseCells are targeting all those underlying kind of, let's say, mechanistic hallmarks of long COVID. And they're basically helping to kind of reboot the immune system. But what I would say, the results that we've seen personally that are yielding the best results is when we combine it with some sort of apheresis technology. I don't know if you've heard of like HHO, hyperthema, hemoperfusion, or immunopheresis. Is basically, it's kind of like blood cleaning, you know, where they remove inflammatory cytokines and they remove this toxic burden from your body, and they're being used in Europe widely. And so basically we do that first. So imagine you remove the bad stuff, you remove those inflammatory toxins, the toxic burden, and then you infuse them with the MuseCells. And then that's kind of our, I guess, protocol, you could say, so to speak, to get good results for these patients.
I was intrigued by your biologic age test, I think system test.
Yeah, system generation lab.
Yeah, is it based on DNA methylation? Is it a methylation region?
Yes, it's still a methyl, yes.
Yeah, I
Yeah.
see. And how many people did you test in that? Or was it one person?
No, we just published a few case reports recently, but we're doing it for all of our patients. So we probably have at least 40 or 50, and then we're going to aggregate them all and then hopefully publish a big case series. So that's the plan right now. So everyone who does the IV of the MuseCells, we pretty much, now we make it mandatory that they do the test before and then they do the test after, so then we can see the data.
I see. And is there a high proportion of patients where you do see a decrease?
Yes, you see a decrease, but that decrease doesn't seem to be permanent. So meaning after like 9 months to a year, it does tend to go back. So I think these are infusions you have to keep doing every year to maintain their benefits.
Yeah, very, very interesting.
Yeah.
Dr. Khan, thank you very much for your speech. We learned a lot. Thank you very much.
Thank you.
And I have a question. I am a 78-year-old man, and I am a scientific biohacker.
Yeah, you look amazing for 78.
Of course, I know that. I know, thank you very much. And I know you have a place in Mexico to stem cell treatment, and I have had for 2 years the treatment in Mexico once a year. But I want to know if the recommendation is okay one time a year or could be better several times a year, please.
Yeah, as I was explaining, based off the data that we're having, I think it depends on your age and probably how fast your body's aging. But I think for people who are generally older, doing these infusions twice a year seems to be a pretty effective way to significantly slow down the aging process in the body as measured by systems age.
Okay, thank you very much.
Can you explain a little more on why the cells are not rejected? You mentioned briefly that at the end you will say, I wonder why the cells are not rejected in these heterologous.
They have low levels of HLA antigen. So their expression of HLA antigen is very low, HLA-A, and so your body doesn't recognize them as foreign or something that it needs to get rid of, and that's the reason why they're able to kind of integrate into your body. So that's the main reason, is the HLA antigen.